By the people, for the people, the gathering to get healthcare now. Chapter 20. Reports to the IPA from the insurance companies. Enrollment and claims data are about the only information the insurance companies report to IPAs. Financial data shows that the details of administrative costs are usually only available in the reports to the state, and it is general rather than specific to the IPA. In the IPA reports, administrative and marketing costs are assumed to be 15 to 20%. There may be equity in that assumed percentage. When compared to the public reports, our company found that about 1/3 of the assumed cost, 5 to 7%, was equity. And sometimes the insurance companies will form a separate claims and administrative company, and the equity in the assumed administrative charge will disappear into that black hole. There are some advocates of a single payer system that say the administrative load should be about 3 to 5%. But in those instances, they're only focused on claims processing and accounting. The cost of enrollments, medical utilization management, and administration of the medical groups and investor profits are not included and are assumed to be unnecessary. Those are real elements in the whole healthcare system. And I think their cost may add another 3 to 5% to the cost, ignoring profits in the private systems. If it is a private system, they could automatically enroll everyone and avoid the marketing and sales cost altogether. But it's likely they'll have some complex enrollment system like they do for Medicaid. Communications about hospital and emergency room encounters are usually kept in note files at the utilization review department level and are shared daily with the IPA. Companies that do not do this are not depending on the IPAs. Hospitalist and medical director to control cost. Consequently, they don't control cost, but depend on the nurse communications between the staff and the hospital's case managers. The reports that are produced by the company show enrollments, premium income, assumed administrative expenses, incurred but not reported claims, hospital claims, other facilities claims, professional claims, capitation for other medical services such as mental health, dental and vision, pharmacy, and transportation. These reports can be sorted from the level of the individual patient to the primary care provider, to the local IPA, to the regional IPA, to the company. You can also sort the data by diagnosis, procedure, and location. These sort options allow you to see what variations there are in the practices of the individual providers. Physicians who code more elaborately and those who code moderately stand out from the mean average. The prevalence of certain diseases becomes apparent. Despite comments previously about the corruption of the underlying data, because it's driven by billing and collections, it's still interesting from a financial perspective. No physician would depend on the data in these reports to treat a patient. The patient and his or her real medical record would be needed to make valid judgments about a medical problem. But in general, the medical conditions and their cost, which are derived from these database sorts, point the medical directors to the physicians and patients they should question. Of course, the more accurate the claims reporting when compared to the medical record, the better the system will work. If the companies give the raw claims data to the IPA in a flat file, then other kinds of reports can be produced which further define what's happening between the physicians and patients. An example would be a report that showed how many unique patients were seen by each physician, both in the IPA and outside of it, and how many times they were seen, and how much money was paid per patient per encounter. That kind of information is important in the distribution of performance bonuses because it causes you to distribute the surplus money based on labor rather than just ownership. There's sometimes an assumption that the IPA organizers, medical directors, and hospitalists have more to do with the creation of surpluses than the care given through routine encounters with patients. It's not true. The more you report from the raw data, the more democratic the organization looks. Routine work by PCPs is about equal to the specialist contributions to surpluses in the acute encounters they have with patients. A performance bonus is Orwellian, for the workers should have some of the profits, but selectively, of course, so they do not attack the established order. The fight between the payers and the IPA is about who will make the distribution decisions. IPAs can win that fight, but must prove that they will not violate CMS's or the insurer's rules about performance bonuses. Naturally, in what is in our country assumed to be a capitalist Republican democracy, everyone concedes that investors get the first count. Investors often use borrowed money to create IPAs and must pay it back at usurious rates of interest. Their shares not a performance bonus, but a return on investment. Those selected for bonuses are the providers of care, usually primary care physicians and some key specialty groups. The general rule from CMS is that the bonus should not exceed a third of their compensation during the year. Further, bonuses should be tied to some preventive measures that are thought to be useful in maintaining good health, such as annual physical examinations and cancer screening and flu shots and prescriptions that control blood pressure and cholesterol levels and heart disease and diabetes and glaucoma. It is possible to glean this information from the claims database and use the report to support your distribution of bonuses to the selected providers of care. Medical groups, by necessity in this culture, operate within an economic system that requires capital to function at the most basic level. Certain members of the group and their managers invest that needed capital. In most cases, the investments come from borrowed money or from savings, and over time have an interest cost as well as a requirement to pay back the principal. Our IPAs, which are a network of 3 local groups, have invested $2 million in capital during their development phases. Our company had to organize the individual practices into teams, contract with the insurance companies for enrollment of patients, and establish our general administration, legal and accounting services. Debt service and restoration of the capital cost of our owners and managers is $15,000 per month, and the only source of repayment is from the bonuses paid by our contracted insurers. Our company has received as much as $4 million per year in bonuses on a population of 6,000 patients, so that restoration of capital and distribution of incentive money to member providers was easy. IPAs in many cases have similar levels of attributed patients, but getting shared savings from CMS programs has been impossible for 80% of the IPAs and slow to collect for the other 20%. It's not like the Medicare Advantage plans that pay a global capitation, which includes administrative fees. It's more like a rigged roulette wheel guarded by the casino's police. Consequently, the IPA cannot afford to depend only on attributed patients from CMS to survive financially. So many did rely on that shared savings bonus and quit when they did not receive it and ran out of capital.